I think Progress Towards Elimination is a good title, but quite optimistic still, I think. I think we still see more new infection than the numbers we are treating today among people who inject drugs. So, excuse me. Are you helping me with this? Thank you. So this is just to remind you of the high prevalence you see all over the globe, where you look for hepatitis C in the injecting drug user community, you'll find a very high prevalence. And in this study published in Lancet, it's the antibody prevalence we are presented to, but you see it's 60 to 80% in most populations. Looking at chronic hepatitis C, it's often 40 to 50%. Highest I have seen is maybe 65%. So that's maybe an upper limit, I don't know. So if you count the numbers of antibody positive people who inject drugs, you'll come to 3 million people in Europe. 3/4 who have chronic infection, and then globally we are talking about a population of 10 million people. So this is a new publication which gives us some very interesting view on the disease attributable to injecting drug use, the part of the HCV-related disease. And you see the red numbers means that most of the HCV consequences are in the drug user populations, and the blue, and it is other routes of transmission. Looking at Europe, you'll see that the burden of HCV-related disease attributable to injecting drug use has been increasing, of course, since 1990. So looking at Western Europe, you see that it was 376,000 dailies, mostly due to lost life years, increased to 700,000 in 2013. And you see the population attributable factor is increasing. So it used to be more important with transfusion-associated hepatitis in Europe in the 80s and 90s. Drug use has now taken over. And you see even stronger tendency in Eastern Europe, the same tendency. Globally, it's 23% in 1990, increased to 38% in 2013. So when we talk about people who inject drugs, we should maybe take care to define the population. And we could talk about people who inject drugs as lifetime experience with drug use. And that would mean, in Norway, for instance, that 80% of Hep C patients are people who inject drugs. But a lot of people have stopped taking drugs. So let's define, in this debate, people who inject drugs as those who have injected the last 12 months and those who are on opiate substitution treatment, or both. So this is the population we are talking about now. So looking at Norway, you see that to the right, it's probably representative to most of Europe. You see people, the yellow part are Hep C patients who have never injected drugs, approximately 1/4 in Norway. The white is the 1/4 who has injected but who has stopped injecting. And then you have those who have just sporadic drug use, about 15%. But then the bluish are the ones who we would now say are people who inject drugs, which should be about 1/3 of the Hep C population in Norway, and probably similar all over Europe at least. And these are people who have not been treated. So in the interferon era, we calculated 1 to 2% would be treated each year in this population. We looked at this in Norway, and we found that from 2004 to 2014, about 15% of patients on OST with Hep C had tried treatment, not achieving SVR necessarily. So I would also like to remind you that when we now have these great phase 3 trials of the DAAs, we should remember that this important Hep C population was excluded from the trials. So maybe people on OST not injecting would be allowed into some trials, but those who have recent injecting practice would not be allowed. So we have mostly been treating those with an experience prior, but who have stopped using drugs. So we have a network called the Activate Network, initiative from Sydney, where we, in a global collaboration, try to do the phase 3b trials in this population. So we have one study, the Simplify study, which is Epclusa in current drug users, and then we have the 3D treatment in people on OST, eventually using drugs too. This is our ongoing trials. We will have data for ESO. But post-hoc analysis of the big phase 3 trials gives us some information on the OST population at least, and it's encouraging. It's really good results. So if you look at the gray bars, it is the Harvoni trials. You see 94% SVR, same in the 3D trials, and also now in the Epclusa trial. So it's the same response rates in people. So this is encouraging and not surprising, actually. But there is one phase 3 trial that has aimed at including patients on OST, and that's the Costars trial. And that is the Salpêtrière study, which included 402 patients, either on OST and some actively injecting drugs. 12 weeks and SVR, and then a 2 or 3 year follow-up after SVR. And interestingly, and maybe not surprisingly, in this OST patient group, we see that 20% probably inject opiates. Coke use was present in 10% during the trial, and amphetamine was also used. And we should maybe note that there is no decrease during the study. So you could maybe hope that people would inject less after seeing a nice doctor every 4 weeks, but that doesn't happen, actually. So we shouldn't be naive. So these are the results from the Costars study, which is similar to what we've seen in other 3D phase 3 trials. So 95% SVR rates are great. And the only thing we should note here is reinfection now is shown as an issue. Maybe not a huge issue, but at 1 year follow-up, we see about 2% reinfection rate after achieving SVR, and maybe a tendency that the reinfection rate is falling through time. Adherence was super in the Costars study, maybe even better than in non-OST populations. So 97% took almost all the doses. There were 4% who missed up till 3 doses. So it was extremely good adherence. And maybe as it's co-administered with OST, it shouldn't surprise us. So people will now ask us about reinfection, and we do have some data from the interferon era. So we have been looking at reinfection also in people who were treated for Hep C while taking drugs. And as you see, there are always small trials. So we have 9, 10 patients. The biggest trial we published now was 37 patients who injected drugs after SVR. And what we see in these studies, if you do a pooled analysis, around 5% per year in this population seems to be reinfected. But of course, in young injecting drug users who have never been infected to Hep C, you often see 10-15% incidence. So explanation is probably that we are treating somewhat older patients. Some of these patients are on OST. They have had access to healthcare, so maybe when we move on, we will see even higher reinfection rates. And I would remind you that 5% per year, we looked at our patients 7 years after SVR, and 1 in 3 have been reinfected. So there is an issue when you look at current drug users. So can we treat and prevent? This is just theory, I remind you that. So it's all reason to be optimistic, but in theory we should be able. So these are models done by Matt Hickman's group now in several European countries. Hopefully it will be published soon. And I'll just show you the example of Norway. So we have about 45% prevalence of chronic hep C in the drug user community. And if we continue, as we did in the interferon era, we will of course stay there. When we switch from not so effective interferon to effective DAAs and treat the same number of patients, we will be in the green box, not much will happen. So if we double the treatment uptake, which was extremely low, not very much will happen. We have to switch to DAA and treat 50 per 1,000 drug users per year to have a real impact within 2025. And this seems to be the same all over Europe. And if you look at Sweden, where they have no access to clean needles, you see very high prevalence, and you see how difficult it is to get the prevalence down when it's up in 65% in the community. So case Norway, about 15,000 people are in the people who inject drug community. We have to treat 800 per year to reach a prevalence of 2% within 2025. So 800 per year doesn't seem too bad, but think about it that prevalence will fall and we still have to find the 800 patients. So when we are down in 10% prevalence, then we will have to treat every second patient. So the pressure will increase, and the last ones to be treated are the most chaotic. So we shouldn't be naive. And if we stop and we start to relax, it will come back. So this is what Margaret introduced a little. So you need models of care and you need to use your fantasy. And I think this is where the fun will be for us as professionals in the future, to find local solutions. So in Norway, for instance, we have drug clinics where people live for 3 to 6 months. Very good for us to access those clinics with mobile clinics. We heard about prisons. Some countries, tertiary care will be the place, but I think that is what we're doing today, not succeeding. Some countries, primary healthcare might be engaged. I'm sure it will be a big challenge in Norway. They have their focus other places. So this is just one model of care which we have developed the last couple of years in Oslo. So it's a low threshold facility that was already there in downtown Oslo. Its tasks is emergency housing, it's a health clinic, injection room, needle and syringe exchange program, been there for 10 years. So we now have access to one GP who works on Hep C, 2 nurses who have this as their task, and then I come every 14th day to sign the prescriptions. And we do the fibroscan. And sometimes we move out and do the fibroscan at housings around the city. Very flexible staff. They know the community very well. They have a tight network in the area, and they tailor treatment. So basically we do, as Margaret said, we ask the patients, do you need that? Do you need a pill box, or do you just need a prescription? And the experience is quite good. So this is in a way the cascade. So we tested 270, found that most were antibody positive, and again 185 tested PCR positive. And then of those 185, as many as 150 came back to have a fibroscan. And then we have no possibility to treat people with liver elasticity below 7 kilopascal. Among those 77, we have treated 45, but genotype 3 patients are waiting for better treatment options. So it's mostly limited access. So patients have been engaged strongly. So treatment uptake until now has been extremely low. But we have now shown that people on opiate substitution treatment is effective, excellent adherence, comparable SVR rates to other groups, and we do see, not surprisingly, that reinfection occurs. So it's in theory possible to treat for prevention, but it requires a great scale-up among people who inject drugs, especially those who have recently injected drugs. Thank you.